Hi, I'm Orion Evans, and we are here today to explore some aspects of COVID. The disease is COVID-19 or coronavirus disease. The virus itself is called Severe Acute Respiratory Syndrome Coronavirus 2 or SARS-CoV-2 or the virus responsible for COVID-19 or the COVID-19 virus. These can all be used interchangeably. I actually tend to take a shortcut and just call it SARS-2 to distinguish it from the original SARS. As you probably know, the symptoms of COVID can be varied, including fever, lower respiratory symptoms, upper respiratory symptoms, headache, weakness, vomiting, diarrhea, fatigue, body ache, loss of smell, and neurological, cardiac, and kidney complications, including blue toes. About 80% of people with COVID have mild, if any, symptoms, but it can escalate from mild to severe very quickly and even result in multi-organ system failure and death. COVID-19. This virus was unknown 9 months ago. We call it novel because it's new. We've come a fairly long way in understanding this complicated virus in a fairly short time. Some of our knowledge is based on previous work with the original SARS virus. There's a tremendous amount that's applicable and a certain amount that really isn't. This is a very different virus in many ways. And it's also worth noting that to date, there is still no effective treatment or vaccine for the original SARS virus. We can't cover everything, every aspect of the virus, disease presentations, the course of the disease, epidemiology, every aspect of the research, different treatment modalities that are being looked at, the genetics of transcription factors. And new stuff is being discovered every week. There are things in this lecture that were only published a few days ago. And we may have a different understanding in a month. So I had to make some personal judgments about what was included based on my interests and what I thought would add to your understanding. And so if there's too much detail, I'm sorry, or if I haven't covered certain things that you think are important, I also apologize. Hopefully you've had a look at the immune lecture that I prepared for you ahead of time. But let's look at a summary of what a virus does. A virus is like a stranger that comes to your neighborhood, and it wanders around the streets in your neighborhood, and it tries the doors on the houses looking to get in, and the doors are locked, and then it realizes, oh, I have a key, and it starts checking out the key in the locks, and it finds a door that it opens. It says, okay, I'm into the house now, but oh my gosh, it's wearing all these heavy coats. And it was like, it's really uncomfortable with all these coats. And what do you know? There's somebody in the house who says, please, sir, may I help you with your coat? Your coat comes off. Then you make yourself at home. You get into the fridge, you turn on the lights, you turn on the television. You get into the bedroom and do some things. And you use lots of energy. And before you know it, you start making copies of yourself. And before you know it, you have thousands of identical strangers. And then all these strangers are like, oh, it's a little crowded in here. We need some more space. And they leave the house. They leave the house by opening the door, or maybe by a side door, or maybe by busting the house open. So that's the life of the virus. And the virus then goes on to find new houses to break into. The life of our immune system is to try and prevent that from happening, to slow it down or to stop it if it's already happening. So we want to keep the stranger out of the neighborhood. We want to keep the stranger from using that lock. We want to maybe put a block on the lock, change the key. We want to keep the stranger out of the fridge and out of your bedroom and unable to make copies. Or if none of that works, to actually kill the stranger or to destroy the house the stranger's in so it can't do any more damage to new houses. So let's have a look at some of the details of coronavirus 19. SARS-2 virus can be transmitted in a number of different ways. Respiratory droplets can be spread into the mouth, nose, and eyes by direct, indirect, and close contact with the droplets, which are produced from sneezing, coughing, singing, or talking. New research indicates that aerosol transmission may also be occurring. These are smaller droplets that are created from talking or even just breathing, microdroplets. They last for much longer, up to 3 hours, and they can travel longer distance. They're particularly a problem in poorly ventilated areas. It is possible to ingest the virus. They have found that the virus is long-lasting on surfaces, more so than most viruses. It can last up to a few days on plastic and stainless steel. So in theory, you could touch a surface, and if you then touch your eyes or nose or mouth, you could be infected. I would say that there's a difference between finding virus particles on a piece of cardboard and having that virus be able to actually be viable and cause a disease. And in fact, there is a fairly rapid half-life of these viruses, so if somebody coughs on a cardboard container and you pick up that container a few hours later, there will be particles, but they will already have started to decay fairly rapidly. SARS-2 is also found in feces and urine, so oral fecal routes are of concern, as is flushing the toilet with the lid up, so please encourage your patients to close the lid before flushing. The reality is most people get infected through close contact transmission. This would be family members, also sharing meals, being in enclosed spaces like the gym and churches and office spaces for more than, say, an hour. SARS-2 is about 1,000 times more infectious than SARS-1. The other thing that has been studied is whether people without symptoms can transmit the disease. And here's the current belief on that. Asymptomatic people may not be infectious. However, pre-symptomatic people are highly infectious. Also, young children who may never develop symptoms can carry high viral loads and be infectious. In the immunology lecture that you may have seen before, we talked a lot about the immune system responses, and we will go over some of those again later. But basically, you have barriers to try and keep the virus out. Acid in your stomach, cilia in your airways, tight junctions in your mucosa. You have a series of innate immune responses which are designed to recognize a general pattern of a pathogen and react very quickly. And then you have adaptive immune responses which are designed to recognize a specific antigen, in this case specific proteins on the SARS-2 virus, and respond accordingly. SARS-CoV-2 is a coronavirus. Coronavirus is a group of viruses that look like they have a crown. It includes the common cold, SARS, MERS. It has a basic structure of genetic material, capsid proteins, and an envelope. Here's an overview of the virus infecting a cell. A virus finds a cell, it attaches to the cell membrane, It enters into the cell, leaving its viral coats and envelopes behind, then takes over the machinery of the host cell to make new genetic material, new proteins. It assembles into new viruses, and then it leaves the cell. This is a picture of SARS-CoV-2. It has an RNA. It has a nucleocapsid, which is a combination of that RNA and N proteins. It has an envelope, which is a lipid bilayer with proteins that are embedded in it, M, S, E, and HE. We're going to have a brief look at each of these. So the nucleocapsid is a combination of the RNA and the N protein. The RNA is a single strand. It's fairly large for a virus. About 2/3 of it codes for replicase, which helps it make new genetic material. The rest of it codes for structural proteins and other non-structural proteins. Because it's an RNA, it can duplicate quite quickly. Normally, the DNA has to make an RNA copy. The RNA copy has to go to the endoplasmic reticulum where proteins are made, and then to the Golgi complex where they're put together. But the RNA comes into the cell ready to start to work. So the RNA and the N proteins are put together into this helical structure, which is then surrounded by the envelope. The envelope is a lipid bilayer with a variety of proteins that are stuck in it. These are structural proteins. We're going to have a quick look at each of them. Here we have a nice picture of the COVID-19 virus. The spike protein is really important in COVID-19 research. It's pivotal for infection and entry into the cell. It attaches to the host cell membrane in a fairly complicated way, and it gets that virus into the cell. Basically, it has a receptor binding domain, and that binding domain attaches onto receptors on the host cell membrane. The result is endocytosis. The virus is brought into the cell, and then other host enzymes also help it to get to work. Here's a little more detailed look at the spike protein. It has two subunits, S1 and S2, that are initially folded and inactive, and in fact hidden by a carbohydrate cap so that it's much harder for the immune system to recognize. The S1 unit has the receptor binding domain, which binds to the host cell membrane. Then the host enzyme furin cleaves that protein. The S protein kind of unfolds, it's like a spring that releases and exposes the S2 subunit. The S2 fuses with the host cell membrane and gets into the cell. Here's another couple of looks at how it does that. You can see in the picture on the right this thing labeled TMPRSS2, which is another protein in the host cell membrane that helps the SARS-CoV-2 get into the cell. Okay? So it's not just ACE2. There are a number of different receptors on the cell membrane and in the cell that have to be working in order for the virus to get into the cell. Here we have a picture of the spike in orange, and the ACE2 receptors are blue. We have a picture of that spring-like action where the virus and the cell membrane start talking to each other. And here's a picture of that receptor binding domain opening up. And there's a picture that says antibody, and that shows how the antibodies can hopefully block the spike protein from attaching to the cell membrane. Okay, so there are a bunch of other proteins, and these are structural proteins. These are necessary for the virus to put itself together, to make new viruses. The M protein in particular serves as a scaffolding, if you like, in the Golgi apparatus to put together the various proteins. So in the cell, new RNA is made. The RNA directs protein production. The proteins are made, S, M, E, H, E, in the endoplasmic reticulum, and then they move into the Golgi apparatus. The N proteins are made. They combine with the RNA to make a nucleocapsid, and they also go into the Golgi apparatus. Viruses are put together, they're put into little vesicles, transported to the cell surface, and then pushed out of the cell. Here's a picture of the various activities that are happening in the cell that you can come back to and look at. Here's another picture. This is basically how the stranger gets to your neighborhood, gets into your house, uses everything in the house, makes copies, and then leaves. All right, I'm going to show you a few nice pictures. Here's some viruses, those circular things outside the cell. Here's viruses attached to the cell surface. This is actually MERS virus, but I thought it was a great picture, so I put it in. Again, those dots are all viruses in the cell. And here you have clusters of viruses in that round bit, that's the endoplasmic reticulum Golgi vesicles. And here they are, the arrows, those dark arrows show the virus budding off and leaving to find new terrain. So here is a summary of this again. The virus attaches, the S protein attaches to the cell membrane, gets into the cell, loses its envelope, starts replicating, starts making new proteins. The proteins and the RNA are put together into new viruses, they get a new coat, and they are sent out. Now that we have an understanding of how the virus gets into, replicates, and leaves the cells, let's look at how our immune response works against the SARS-CoV-2 virus. Basically, the virus enters the apical surface of epithelial cells in the alveoli of the lungs. It can infect many other cells, but for the moment we're going to just focus on that. And the first thing that happens is the innate immune response, which quickly recognizes that there's a pathogen. Dendritic cells live under the epithelium. Alveolar macrophages live right on top of the epithelium, and natural killer cells are abundant in the lung. So those three cells start to get to work, and you start to get some cytokine and complement release as well. Within a few days, you have an adaptive immune response. We'll begin with the T cell. So the T cells are the primary mechanism of viral infection, control, and memory. The dendritic cells and the macrophages present the antigens to the T cells. It's a little unclear how this happens, but the research so far indicates that the normal mechanism where these white blood cells eat the virus and present the antigen on its surface seems to be what's happening. They travel to the lymph, they visit the naive T cells, they say, hey, have a look at this virus. We don't like the look of this. And these naive T cells get activated into CD4 cells, the helper cells, CD8, the cytotoxic cells, and the memory T cells travel to the infected site and get to work. Here's a picture of that cycle of the dendritic cells in the lungs getting infected, going to the lymph node, and the T cells going back to the lungs. The helper CD4 cells orchestrate the immune response and also activate B cells to promote antibodies. The CD8 or cytotoxic cells can kill infected cells. Higher CD4 counts are correlated with better outcomes. And the memory T cells seem to be very important, more important than antibody counts. There's some indication that memory T cells are still robust, certainly as long as 6 months, even without antibodies present. The T cells sometimes get into trouble, okay? If you have high CD4 cells, you have a better outcome. But sometimes in moderate and severe COVID, you end up with lymphopenia, which is lower CD4 and CD8 counts. These T cells seem to be exhausted. This is more prevalent in the elderly. It's present in moderate and severe cases of COVID, and it's definitely associated with higher morbidity, higher mortality. And then we have the adaptive immunity B cell response. As we talked about in the immune system lecture, antigen-presenting cells activate the helper T cells. The helper T cells activate the B cells. The B cells become plasma cells. Plasma cells make antibodies. The antibodies bind to the antigens and hopefully neutralize the virus, prevent it from entering into the cell, and flag it so it's more easily seen by phagocytes. There certainly are more antibodies in a more severe response, but it is still open to debate about how relevant or how helpful antibodies are. When do they show up? How long do they last? Are they actually doing their job to neutralize the antigens? Or are they perhaps exacerbating the problem? These are questions that don't have answers yet. But here's the picture of at least the theoretical action of the antibodies. And this seems to be the case in people with mild COVID, people who have recovered from mild COVID. Their plasma with antibodies seems to possibly be helpful for people who are infected with COVID. So here you have the activated T cells activating the B cells, the B cells differentiating, making antibodies, and neutralizing, basically covering up the spike proteins on that virus so that the spike protein cannot attach to the host cell. And then we have the cytokines. Now remember, cytokines are part of the normal and successful immune response. They are increased during infection to coordinate a response, and then they go back to normal. This definitely happens in most of the cases of people who have COVID. However, if you get a cytokine storm where the cytokines cycle out of control and you get excessive pro-inflammatory cytokines, particularly IL-6 and IL-8, ferritin, TNF-alpha, inflammasome. There's a number that have been correlated with T cell and natural killer cell lymphopenia and more severe COVID reactions. eventually resulting in possible organ failure and death. Finally, there's the question of reinfection. This is a question that doesn't have an answer yet. It does seem possible that people can be reinfected, but it also seems almost definite that if you have had COVID, you will have some protective immunity so that a second infection will be far less serious. And I also want to emphasize that T cell counts, memory T cells, seem to be conferring immunity more than antibody counts. I want to have another look at the interaction between the spike protein on the virus and the receptors on the host cell membrane. These include the ACE2 receptor, but also a number of other receptors, namely TMPRSS2, don't ask me what it stands for, TPC2, furin, and inside the cell there's another enzyme called CTSL, which seems to help the virus once it's in the cell. And these basically all need to be present to bind the virus, cleave the virus, get the virus into the cell. So we know that the ACE2 receptor interacts with the receptor binding domain of the S protein. We know that these receptors are found in type 2 pneumocytes in the alveolar epithelium. And we know that ACE2 receptors are part of the renin-angiotensin-aldosterone system, otherwise known as RAAS. I want to take just a moment to talk about the angiotensin and bradykinin systems. These are very complicated. They're to do with hormonal regulation of blood pressure and fluid balance, and they are affected by SARS-2 infections in very complicated ways. We really don't have time to go into it, but it is an area of active research. Just a quick look at the current SARS-CoV-2 versus the original SARS. They have very similar spike proteins with small molecular differences, but that means that the current SARS-2 has 20 times stronger binding to the cell membrane. This means a more efficient infection. Also, SARS only infects the epithelial airway cells. The receptors that it needs are only found in those cells, whereas the SARS-2 has other cells that it can infect, which we're going to look at. Okay, so they have found SARS-2 in the body in many, many different areas. The respiratory system, the gastrointestinal tract, the heart, the bladder, the kidney, the nose, the eyes, and the brain. Basically, this virus gets into cells that has the ACE2 receptors along with different proteases, TMPR, SS2, furin, CTSL. The furin is quite important. It cleaves that S1, S2 subunits of the spike protein that is not found in any other coronavirus. What we found is that the epithelial cells of organs other than the lungs also can be infected, and that the vascular endothelial cells can be infected, and that in fact many other cells, including cardiac muscle cells, can be infected. So, where are the potential entry points for SARS-2? I read a review of about 16 studies, plus a review of cell atlases, where they looked for these ACE2 and other receptors. They found virus-infected cells in the upper and lower respiratory tracts, in the mucosa and epithelial cells of the nose, of the mouth, of the sinuses, of the trachea, of the pharynx, of the alveoli. They found them in the salivary glands, in the cornea, in cardiomyocytes, in heart pericytes, in the olfactory area, certainly in the epithelium, possibly in neuronal cells as well, in renal epithelium, in the brain, although they don't know exactly what cells in the brain are being infected. In the gastrointestinal tract, they found them in enterocytes, and they found them in feces, and they found them in the endothelial lining of submucosal vessels in the small intestine. So we're going to look a little more closely at this vascular endothelium. This was a very important finding. This does not happen in any other respiratory virus. Okay? The virus particles are found in the vascular endothelium. We have 60,000 miles of blood vessels. Okay? This began in April. A number of doctors wrote a letter to The Lancet. They were wondering why there were so many cardiac and other organ complications. And they found that there was endothelial cell involvement in the vascular beds of organs when they looked at them post-mortem. They found viruses in the endothelial cells, and they found signs of inflammation in the endothelial lining of the blood vessels. They found this in the kidneys and in the heart and in the small intestine and in the lung and in the liver. Another paper in July of this year autopsied lungs of people who have died with COVID respiratory distress versus H1N1 respiratory distress. In the COVID lungs, they found 9 times the number of blood clots. They found more dysregulated angiogenesis, where there was damage to the tissues, and the lungs tried to make new blood vessels. They found endothelial injuries. They found viruses in the cells. They found thrombus, and they found microthrombosis in the alveolar capillaries. On the basis of this, they and another paper that was done later that this year have said that COVID may present more like a pulmonary vascular disease. Pulmonary thrombi and microthrombi may be the primary cause of respiratory failure. Okay, that these blood clots are causing the respiratory failure. It's also believed that the predisposing diseases, obesity, hypertension, diabetes, those already have an underlying susceptibility to endothelial injury. So the idea is that the virus gets into the lungs, destroys some of the lung tissue, and then gets into the blood vessels and infects the endothelium. Okay? As I said, this is the only respiratory virus to have been known to do this. Another example, there's a case history published, 43-year-old woman who had transient angina one day. A day later, she had sudden chest pain. She had no fever. She had 100% O2 saturation. She had a normal angiogram, but an abnormal ECG. She progressed quickly to cardiogenic shock, pulmonary congestion, but not pneumonia, particularly left ventricular dysfunction, multiple organ failures, and died. On autopsy, they found microvascular thrombi in both the left and right ventricle walls, no sign of alveolar damage. So this endothelial damage could explain the blood clots, could explain why pre-existing conditions put people at higher risk, could explain why ventilation doesn't work, because if the blood vessels aren't intact and can't absorb the oxygen in the alveolar sacs, you can push as much oxygen as you want and it won't get into the body. Okay, I have a few pictures of the damage of some of these. Here on this first on the left, you have the kidneys, and all those nice dots are viral infections. In the picture on the right, this is a person who died from COVID-19 and the damage that's done in the alveoli. Again, on the left, you have a picture of COVID lung, and on the right, a picture of someone who died with pneumonia from COVID. This is an interesting picture. On the left, you have healthy blood vessels in the lung, and on the right, you have this attempt to repair this dysregulated angiogenesis. On the left, you have a close-up of that abnormal angiogenesis, and on the right, the RC are the red blood cells, and the other cell is an endothelial cell that is infected with the SARS-2 virus. Here's a picture of a 65-year-old man who had COVID, and this shows both this typical ground glass opacities, which you find in COVID lungs, but you can also see the arrows are pointing to dilated blood vessels, and the arrowheads are pointing to engorged blood vessels. So one of the papers wrote this, and I thought it was so relevant osteopathically. The vascular endothelium is an active paracrine, endocrine, and autocrine organ that is indispensable for the regulation of vascular tone and the maintenance of vascular homeostasis. COVID-19 endotheliitis could explain the system-impaired microcirculatory function in vascular beds and their clinical sequelae in patients. So to me, this is really where we are as osteopaths, and can start looking at some of these issues with our post-viral patients, and at the function of the endothelium as the vascular endothelium as being vital to supplying all the tissues in the body. So endotheliitis is a microvascular disruption. Okay? It results in organ damage, tissue edema, inflammation, coagulation. And the authors of these papers believe that this could explain the impaired microcirculatory function in vascular beds. One more piece of research that just has been published in the last few days. It's actually not even been peer-reviewed yet, but it was felt so important that the authors put it out as a preprint. What they did was they took cardiomyocytes in the lab and they infected those cells with the virus. Okay? And basically, very soon afterwards, it looked like those fibers had been sliced and diced. They used the term surgically sliced. Okay? Cleavage of the filaments and DNA damage in the muscle cells. Okay? This is similar to the findings in heart muscles. So they are now concerned about potentially irreversible damage in heart muscle cells. What happens to shift COVID-19 from a mild event to a moderate or severe or even deadly disease? There are a few different pathways that are being explored. The first one is to view it as a vascular event. This is what we've been looking at quite a bit in this lecture, that the blood supply to organs is compromised, that the endothelial wall of the blood vessels is infected and inflamed, and that results in too much inflammation and micro blood clots. The second is the cytokine storm, which I'm sure everybody has heard about. This is when the normal immune reaction, which is to produce cytokines, escalates, and you end up with excessive cytokines. You end up with a buildup of fluid and gel in the lungs and increased inflammation. The third, fairly recent theory is that it's in fact a bradykinin storm. Bradykinin is one of the hormones that's part of that renin, angiotensin, aldosterone, bradykinin system, and regulates fluid volume and blood pressure. So here's the cytokine storm, a normal response on the left-hand side, and an excess of white blood cells and fluid and gel on the right side. Bradykinin storm, possibly resulting in all kinds of serious effects, including heart failure, but inflammation and too much vasodilation, buildup of the hydrogel. So this is an endocrine moderated event. Here's another picture that's a little depressing about this gel that builds up in the alveolar space. Let's talk a minute about post-COVID complications. One thing that's become very clear, and probably you've seen these people in your practice already, is people who have perhaps not too severe COVID, but take a very, very long time to recover. They're tired. Some of these people have lung and heart complications. And it seems more and more evident that there may be lasting complications to the lungs, the heart, the kidneys, the brain, as well as this slow recovery of normal vitality. One of the alarming things is that people may have radiological findings even if they have not had symptoms. So what does this mean for us clinically as osteopaths and the future health of these people? How can we start to perceive in the tissues the kinds of damage that they may have that don't necessarily correlate with their history and their symptom pictures? For example, here's a man who was in his 70s. He had no respiratory symptoms on presentation. He had fever, body aches, gastrointestinal symptoms. He wasn't even tested for COVID initially. 2 weeks after his symptoms began, he had a CT scan, and even though he had no respiratory findings, they found this ground glass opacity in the lungs. This is a typical COVID finding. He never had any airway symptoms during the course of his disease, but clearly he's at risk for future lung issues. You may have heard about the Diamond Princess cruise, where they discovered COVID on the cruise ship and quarantined the entire ship. Later studies showed that 54% of people who were asymptomatic for COVID had lung opacities on their CT scan. Also finding that there are cardiac complications post-COVID, even in moderate cases, or that people had cardiac events while they had COVID without realizing it. They're big, hefty athletes who are showing signs of having heart attacks. It's thought that at least 50% of COVID patients have some kind of cardiac dysfunction. And there's been a couple of studies showing a high likelihood of heart involvement with COVID infection. And no one knows if these heart changes are permanent, if they're going to lead to chronic heart disease. In Germany, they did a study. They did 100 MRIs of post-COVID younger people under 50, healthy, athletic, fit, no previous heart history, recovered at home, were not hospitalized. 2 months after recovery, they had significant findings. 78 of those had structural changes to the heart. 76 had biomarkers indicating they had had a heart attack. And 60 had signs of active inflammation. Germany also did an autopsy study. These people were people who had died, mostly older, over 85. They all had infection in the heart tissue. Let's talk a little bit about vulnerabilities. I'm sure you're aware of a lot of these already. Men have higher infection and higher mortality rates compared to women. They have certainly a higher ACE2 expression, so there's more opportunities for the virus to infect. Also changes in that angiotensin and bradykinin systems, leading to more vasodilation, also more heart conduction enzymes, more risk of heart abnormalities. Children have a much lower ACE2 expression and higher melatonin levels. Melatonin is believed to be protective against cytokine storms. Children, it's important to say, they have mild or asymptomatic presentation of this disease, but they seem to carry high viral loads and possibly high infection transmission potentials. Okay. Women, as well as having lower ACE2 expression, also seem to have some kind of protective factor from estrogen. They're finding out some genetic differences. Type A's more vulnerable than type O. People who have sickle cell traits, not sickle cell anemia, but who carry one of the genes for sickle cell are now, just in the last week, they have found that this makes them more vulnerable to serious disease. Predisposing illnesses, hypertension, coronary artery disease, more risk even if medically managed. We've talked about how those diseases may in fact be already causing endothelial disturbance, making the vascular endothelium more vulnerable to SARS-2 infection. Smoking and obesity also put you at higher risk, possibly because those categories lead to more upregulation of ACE2. And different immune responses between men and women. Men seem to have higher interleukin, particularly IL-8 early on, and a lower T-cell response, whereas women have a more robust T-cell activation. Of course, vulnerabilities are just that. They're just statistics. The worst case of COVID that I've seen to date is a 39-year-old, very fit, no predisposing factors guy. Just because you're a woman doesn't mean you're not going to get COVID. So we do have to be aware. For me, I'm starting to look at this from an osteopathic point of view. What is our role with this? Certainly this entire course is looking at how to treat a post-viral patient, but I think we also have some specific things to do here. For me, over the many, many years of practice, putting my hands on people is like building a perceptual library. If you treat a bunch of people who have had meningitis, you get a feeling. Somebody comes into your office and you can say, oh, feels like you might have had meningitis sometime in your life. So we get a feeling of what pneumonia feels like and what viral pneumonia versus bacterial pneumonia feels like. A couple of weeks ago, where I live, there was a lot of smoke in the air from forest fires, and people were coming in with compromised lung from smoke and also from the allergies that were in the air. And then I had a person come in, and I put my hands on her, and I said, well, you have smoke and you have allergies, but you have an infection as well, and you need to get checked. Fortunately, it was strep and not COVID. But that's what we need to do in terms of learning with our perceptual sense so that we're prepared. So in this later today, I know there'll be labs that'll be looking at perceiving the quality of the vascular endothelium. If you can perceive it in health, you can perceive when it goes wrong, perceiving what's happening in the lung spaces, in the alveolar tissues. And then we'll be prepared for what we find for people who maybe didn't have much of a big deal in COVID, but you put your hands on and you can feel that damage in the lungs. People who you don't expect. And I think over the next, couple of years, we're going to be looking at how we as osteopaths can help people recover from COVID, which may be more difficult and take more time than anyone would really like. And also how to sense some of that damage in the tissues, because not everybody who has COVID is going to go get a CT scan. But if you feel something in their lungs, you may be able to encourage them to have some more testing or to have their hearts checked out. So I think we have a huge role coming up in helping people have a better outcome from COVID. Thank you.